think we're good to go. So good evening, everyone. Welcome back to our bi-weekly sessions. Thank you again for joining us on the alternate Fridays. Without further ado, we'll move on to our first set of cases. It is from Jaipur, from Dr. Vivek. The chat is open. So again, we are welcome to your suggestions and comments for these cases. So over to you, Dr. Vivek.
So this is a 9-month-old boy who actually just stayed with us for 24 hours. And because of financial constraints, they left yesterday. But I did have enough information, and I thought this will be an interesting case just for the differential. And I'm hoping that we will be able to get gene sequencing in the child in future. So this is a 9-month-old boy who had a normal development till 4-month age. The family has shown me the videos, and the baby looked completely normal. And over the next few months, he had regression, initial more motor with increasing tone, dystonic, and then cognitive regression was also there. And he stopped recognizing his family, no response to noise. So there was a complete regression to like a newborn baby. And the dystonia over the next few months also regressed without treatment, and he became hypotonic. And then he developed seizure-like events, which are more like, I have a video, or EPC, epilepsy partialis continua, either on the left or sometimes on the right. So here you see this child. This is a video from day 4 yesterday when they came to us after 5 months of this history. And sometimes it's stimulus sensitive as well. So sometimes it will be on the left, sometimes on the right. Baby is poorly responsive, NG fed, slight dystonia in the left arm, but mostly hypotonic. He was admitted from 6 months to 8-month age for 2 months in the local government medical college in Udaipur, where he had initial investigations done. And there wasn't much significant, but his urine CMV PCR DNA was quite high, 6,000 urine. Even though the CSF was completely normal, including CMV, HIV was negative. So he was treated with ganciclovir for 2 months, and that hadn't worked at all. And he continued to regress. And then they had come to me day before yesterday. In 24 hours with us, we did some investigation in which there was mild thrombocytopenia, which we thought was ganciclovir related. He had a mildly raised ferritin of 500, but basic bloods, nothing was there. His lactate was 22, normal is 19, ammonia was normal. His immunoglobulin profile was normal. I did that because if this TMV was important, whether he had a chronic ongoing viral process because of an underlying immunodeficiency state, because we have had 1 or 2 patients before who had hyper IgM syndrome, who had immunodeficiencies, where this unknown chronic virus causes regressions, but immunoglobulin profile was normal. His homocysteine was high at 42. So that was one thing which was high. Lactate was just mildly raised. And we managed to get an MRI with MRS, this admission. And there was an MRI from 3 months back. So in April, when the initial MRI was done. So first and now this MRI.
Got it. Thanks,
right,
Dr. Vivek.
Nihaal?
Yeah. So first, I've just put in these 3 images. I think these are the ones which demonstrate the findings. The diffusion and ADC sequences. On the diffusion, you can appreciate in the periorganic regions out here and the possibly along the cingulate cortex, you have these areas of restricted diffusion. They show reversal on the ADC sequences. I don't have them over here. Coming more inferiorly into central aspects of the brain, you can appreciate that at least the thalami demonstrate bilateral changes of restricted diffusion, possibly also in the basal ganglia, but more definitively in the thalamus. So we are looking at predominant changes of these cytotoxic abnormalities in the periorganic regions, the deep gray nuclei, particularly more predominant in the thalamus.
So I just wanted to add that the child has been on valproate for last 2 months, along with levetiracetam for these seizures. His there is liver dysfunction, but not severe. So like 110, 120 SGOT, SGPT. And there is no hepatomegaly, right?
Got it. So I think then we have a follow-up 2.5 months later. Was the child seizing at this point of time also, Dr. Vivek?
Just these epilepsy partial, this myoclonus is there. So this is 2 days back MRI.
Okay, okay. Okay, so in the MR, you have the diffusion panel on top, and you can appreciate again some areas of restricted diffusion more confluent in the subcortical white matter, also in the cortex, extending up to the periventricular and deep white matter, especially in the frontal temporal lobes and occipital lobes out there. Possible changes in the bilateral globus pallidi, and also in the, if you come down lower, there in the brainstem, especially the cerebral peduncles and the central tegmental tracts. There is a generalized reduction in the volume, I think possibly added by the medications, and also some changes of neurodegeneration. On the T2 sequences, we have some hyperintensities, which are again seen on the diffusion sequences. So overall, supratentorial volume loss, predominant volume loss with these diffusion abnormalities. Midline sarcomeric sequence, again, you have reduced supratentorial abnormalities or volume, is particularly the corpus callosum out here, and also in the brainstem. And spectroscopy, you have an elevated lactate peak on all the three voxels, which are kept on in, I think, in the basal ganglia and thalami. The choline peak for the infantile age group is relatively normal. That is how the gradient is. The choline is usually elevated as the child is myelinating, but the main finding here was the inverted lactates. I think Dr. Vivek has already mentioned the follow-up investigations. The main finding, I think, were lactates was 22, and the profile, immunodeficiency profile was normal. Homocysteine was high. Dr. Vivek, anything to add in this?
No, that's it.
Okay.
And mild liver dysfunction.
Got it. Okay. So based on the, if you go from an approach to from the clinical side to the radiological side, at least I found this article, which I think published by the Great Ormond Street Group. This is a diagnostic algorithm for possibilities of children with epilepsy partialis continua. If there are bilateral changes, one must think of mitochondrial disorders, Paul-G mutations, and MD should be followed by MD DNA sequences. If there is unilateral abnormalities, think of the possibility of Rasmussen encephalitis. So two of the main, and if it's more focal, then think of focal cortical dysplasias. So these are the three differentials based on the Caesar profile of the child. And then coming down to the imaging profile, at least on the initial sequences, one of the markers which was elaborated by, I think, the CHOP group a couple of years back, is the perirolandic sign, and also the thalamic abnormalities, which can be seen in Paul-G mutations. So unilateral and bilateral involvement was seen in more than half of the patients with Paul-G mutations. The thalamic changes again was seen in around 77% of changes. So the spectrum of partialis continua with perirolandic and thalamic abnormalities, they found around 86 to 70% of patients had a confirmed Paul-G mutation. And on the follow-up scan, the child had disease progression in terms of volume loss. So in terms of one of the primary imaging differentials, we're thinking of Paul-G mutation. The other abnormality is focused on the thalamus, I think, are less likely in this child. So these are the other differentials which can be centered in the thalamic region. I think Dr. Vivek had sent me this reference, thinking of possibility of immunodeficiency associated with infection and meningoencephalitis, particularly viral encephalitis. But our changes, at least on the first scan, is more symmetrical. I think on imaging bias pointing more towards the inherited disorder rather than a infective abnormality resulting in those changes. Yeah. So with that, I'll open the case if there are any further suggestions, comments.
There is globus involvement as well.
Yeah, on the second scan, you can see on the T2s, they're slightly hyperintense, and on the diffusion, not sure if it's projecting properly, but not as significant as what we see in methylmalonic acidemia.
Okay.
Though the volume loss can be seen, but usually have more predominant, striking globus pallidus abnormalities, especially the typical purple pathway disorders or MMAs. And brainstem also can show some signals. So that was the only thing which was. And the first scan, I think, if it was an MMA, again, it would have been predominant globus pallidus involvement, then going to the different nuclei.
And over time, this perirolandic sign disappears. So it's very useful to know the MRI in the initial part of the illness. If it is helpers.
If it is helpers apology, and it can be unilateral or bilateral. So it is one of the initial signs, is what they have described.
I have also considered POLC as a high probability. I'm just a little bit confused about the dramatic course. I mean, the time evolution is very dramatic compared with a few POLC patients I have seen. I mean, genetic testing will be, hopefully, give the answer.
Even though he has been on sodium valproate for last 2 months, the liver dysfunction is there, but not that significant. Maybe that contributed to the progression, the rapid, because he's been on sodium valproate, a good dose sodium valproate for that age baby.
Have you decided to withdraw it or?
No, sir, they had financial constraints, and actually they had been in a government hospital, once. So, and then they come to a private setup. So finance was an issue, and they didn't agree to stay back. So we do have a EDTA sample, and I am in sort of moral dilemma to whether send it myself or because they won't pay for it. So those things I have to sort out. So yeah, we'll try to get the genetics.
Genetics, yeah. Okay. I think Sridhar has put in SCN2A associated development epileptic encephalopathy to be considered hyperhomocystinemia, MMA, and methionine levels for the characterization.
So I do have a patient of SCN2A associated DE severely affected, and that child had cerebellar atrophy, significant cerebellar atrophy from few months age, much more than the cortical atrophy. That's something which does happen in that. But this is I think it's different presentation from this one, because SCN2A patients have more of convulsive seizures. They will be significantly delayed, then polymorphic, migrating seizures. This sort of looks, and they won't be that encephalopathic. This child is so encephalopathic, like any neurometabolic disorder, which won't be there probably in the channelopathies, except for the episode.
Okay. If you have genetics, Dr. Vivek, please update us. So we're thinking mitochondrial pathology as the primary possibility. Yeah.
Only the something interesting which I found, the gang cyclovir does cause significant bradycardia. This child's heart rate has been 50 to 70, 50 to 60 per minute throughout the course, and that was something I came to know while searching for the causes of bradycardia in the child.
Was he on vigabatrin by any chance? I came a little late. I'm sorry.
No, sir, he was never on vigabatrin.
Because vigabatrin also, can
Yeah,
cause
we have seen
bradycardia.
thalamic brainstem dentate nucleus changes.
That can also cause bradycardia.
Okay.
Yeah, you were mentioning for bradycardia, okay, but he was not on vigabatrin. Actually, the focus in the hospital has been treating him for CMV meningoencephalitis.
Yeah.
The question encephalopathy due to valproate toxicity, but child wasn't on valproate. So yeah, from Dr. Viveka.
No, child has been on valproate for last 2 months. I agree.
Sorry. Okay.
Yeah, good dose valproate.
So encephalopathy can be due to valproate toxicity is one of the concerns. Yes.
Right. Is it in Polgy, will the encephalopathy with a normal ammonia still be due to valproate toxicity? That's something I don't know. Is that can still be there, or is it due to the high ammonia? So I don't know the answer for that. So will the valproate toxicity cause encephalopathy if ammonia is high, or otherwise also it can be there in a mitochondrial?
Well, I think you get in mitochondrial disease, you get, basically the alphas, at least what has been described initially was that there were lots of patients who had won valproate, and that's why they died of liver toxicity. And valproate can cause an encephalopathy later on with even normal ammonia, but that's like a, chronic, subacute chronic kind of thing, not like this.
Right. What is HOD?
I think Dr. Vijay, if I'm not mistaken, is hypertrophic olivary degeneration.
Yeah.
Okay.
So that is bilateral hypertrophic olivary degeneration is described with Polgy.
Yeah.
Okay.
I can't see a medullary cut.
No, Dr. Vijay, I can confirm this.
Don't you get changes in the occipital lobes as well?
Yes, Dr. Udani.
I can
As you can-
correct because
Yeah.
I mean that's one of the things we use in diagnosis of Alpers. You also get this, you know,
Posterior predominant. Yes, more
yeah,
posterior predominant.
occipital dominant,
Posterior.
yes.
Yeah.
So this
This-
paper, the perirolandic sign paper, gives that the course of Paul G mutation MRI changes. So initially you have the perirolandic sign, and as it disappears, you develop occipital changes, occipital gliosis.
Correct.
And this child also has it in the second MRI. If one looks clearly right more than left on the occipital.
Occipital
So
changes
clear-
in bulk are not consistent. I just recently seen a follow-up scan of an older child, and initially no occipital lesion, later on one side, later this in fact disappeared. It was reversible. So this is helpful but not consistent.
True, sure. So not always there, but it can be there. So this child did appear to have it.
Okay. So hopefully we get a follow-up to it. Okay, we'll move on to our next case. Dr. Ek, over to you. I think this was previously discussed a couple of times last year in September, October. I think we have a follow-up scan recently.
Yeah, so this is the third or the fourth time I'm discussing this patient. So again, more for the etiology. So this child last year, September, was admitted with us for 3 months. And at that time, he had influenza positive acute respiratory illness in which he worsened and was ventilated at the time for a week and had some steroid as well. And then as he was recovering, we realized he had got bulbar palsy, brainstem signs, and neurological involvement. And his X-ray was suggestive of X-ray, and later a CT was suggestive of a necrotizing pneumonia, bilateral consolidation. So when we did a MRI for this evaluation, there were multiple lesions seen in the brain as well. His ferritin was normal. And we had done an exhaustive workup. We had discussed this patient, and the jury was that this is a fungal infection. Galactomannan was mildly raised in the blood. So we treated him with voriconazole, and which he has been for the last 10 months. And serial MRIs have been done. Overall, so initial first 2 CTs has shown bilateral consolidation with some cavitation, and there was a vasculitic process, and there was also aneurysm, a small aneurysm in the one of the pulmonary blood vessels in the initial CT, causing recurrent hemoptysis. So he was in a really bad state for the few months, and then he came out, and now over the last year he's recovered really well, except that he has these episodes every month, few times, where after some exertion, when he's been running for some time, he suddenly stops, like a temporal lobe semiology seizure where his behavior arrests, cyanosed, and then he recovers. So we had been confused whether it is his lesions which are still causing it, or he's got something in the lung which is causing the problem. So that's why he has had serial MRIs, and he also this time, 3 days back, had a last MRI with a CT chest. And this time the CT chest does show that he is evolving into an interstitial lung disease. So maybe not the brain, it is the lung which is causing these events. Otherwise, he's recovered completely. And he continues to be on voriconazole. So he has had around 3 or 4 MRIs. So I just wanted to discuss, are we still on the right path? They haven't agreed because he also has short stature. He had a history of infections in the past. So I was hoping if we could do a genetics for HLH and for immunodeficiency, but I still haven't been able to convince them.
So as you can see, the MRIs, we had multifocal abnormalities. This is in September 2023, supratentorally, infratentorally, predominantly in the brainstem medulla out there. They showed some distributed diffusion, some blooming contents, particularly in the periphery of these lesions. There was this ill-defined or ring enhancement demonstrated in most of these lesions, with some nodularity along the walls. On the follow-up scans, I mean, there's still multifocal abnormality. This was 2 weeks later. As Dr. Vivek has mentioned, the chest findings. I could not put up the recent chest scan. I think there was not opening, but yeah, this was the chest scan. I think last year had consolidation, cavitations, and aneurysm, which is not, I think, cannot be demonstrated here on this scan particularly. Then again, on the follow-ups, the lesions demonstrated interval reduction in the size. I think the edema was slightly more compared to the prior study in the September. So lesions, again, as you can see, they have reduced in size. They are more nodular enhancing lesions now, more granulomatous appearance. And this is the most recent scan, and you can appreciate that there is significant interval reduction in the lesions compared to the baseline scan. Most of them have demonstrated T2 hypointensity as possibility, of calcification or mineralization of granuloma formation. And you can see that the lesions have considerably reduced in size. At that point of time, I think Dr. Vivek has already mentioned, we thought of infective etiology as fungal was the most consistent at that point of time. And yeah, these are just differentials for these ring enhancing lesions. And we went with fungal abscesses as the most likely possibility. The question here is, I'll open the case. Are we still dealing with the fungal abnormality given that the response on the follow-up scans, and do we need to test for genetics?
So you treated with oral voriconazole, Dr. Vivek?
Yeah. So initially we gave IV because IV voriconazole causes severe hypokalemia in I think half the patient, it caused in him as well. So after a few weeks of IV, we had to shift him to oral because he had severe hypokalemia, like 1.5 potassium. And once we shifted to oral voriconazole, it resolved.
Okay. But the fact that it has improved so much over the last year suggests that it's probably a fungal etiology, no? But you just need to find out why he got a fungal CNS infection.
And in the lungs now, he's developed an interstitial lung disease. So cystic fibrosis is also a possibility, whether it was an atypical organism in the brain. So, and this one looks more like a tuberculosis. This was the first MRI.
But not on ADT, not Dr. Vivek? Anytime?
Sorry, no, he's not on ADT.
Yeah.
No.
How long you plan to give the voriconazole for?
When I search the literature, there is no answer as how long, but in 2 more cases in the past, I've given for 1 year, total a year, and he now has developed, calcification, edema is significantly less, maybe 2-3 more months, which will make it 1 year. But maybe I also wanted to ask you all what I should do. Should I be continuing or stop it now? Because there's still some edema, so maybe still some activity. So, and he hasn't got any side effects to it. And it's also very interesting. I realized that one has to do voriconazole levels because when we started it, we just get the typical dose, 6 per kg, and then the levels were really low. And then we increase it to the highest possible dose, then the levels reach the right amount in the blood. And then he started to probably respond.
You had some interesting seizure semiology. What did you say? You said some exertion.
What happens over the last 6 months, the reason for doing these MRIs has been because of these events. Every month, 2-3 times. So he's been, what family says, in the morning when he wakes up and he's running around and playing, suddenly he stops. He has a behavior arrest. There's no version. He just is quiet and he's cyanosed, desaturates, and within a minute he recovers and is back to normal. So
you think it's the lung or the brain?
So that was my confusion because he's got temporal lobe edema on the left side.
Yeah, I'll just tell you a case I had. This was a child who had, he didn't have anything in the brain, was normal. I mean, he looked a normal kid, but he had what looked like temporal lobe seizures. But every time when he was running or climbing stairs or anything, he would get this episode, exactly what you were saying. So first my thought was that it was actually some sort of cardiac problem. Though I could not understand why he was not falling or anything, but he would become a quiet, stare, have some movements and all that. And we did everything cardiac, stress test, everything we did, everything was normal. And finally he responded to anticonvulsants. So I think maybe you got another case like this, except this is a...
But I've been giving him 2 anti-seizure medicine already, oxcarb, again Levipil in past, now he's on Frisium. And cardiologist has seen this time, and the parents are nursing staff, so they always have a pulse oximeter on. When this happens, they try to put it on. And feel his pulse. So they couldn't feel any rhythm disturbance, and he gets tachycardia.
So probably this is a very rare entity. I read about it later. There's an exertion-induced temporal lobe seizures.
Okay.
Odd. I never really heard of it till I saw this case and I reviewed the literature, but it was interesting.
But his CT chest now shows interstitial lung disease.
So maybe that was contributing.
Yeah.
So Dr. Vivek, at least neurology wise, the regions have come down. That is what I can say.
Right.
Sorry, I wasn't able to open the scan. They sent it.
No, that's fine. So maybe, but still, genetics I feel should be done. Something comes out by chance, because it's very odd for him to what he has had. And I wanted to ask Dr. Udani, sir, would you give voriconazole for a few more months here?
Frankly, I'm not the expert on this, but I refer to they usually give it for a year.
Right.
Yeah, we had one patient, for example, who had a fungal infection after a post-traumatic injury. Of course, that time there was no voriconazole, and he had some funny saprophytic fungus from the road which had gone into and caused an abscess. That child finally he went on for 3 years, and his father had learned how to give and that's what was happening. I mean, for 3 years he gave it because it would just become bigger. So it was. I don't really know the answer to this, like. But I think 1 year and then wait and see what happens.
Yeah. Thank you.
Okay, thank you. So next case from Jaipur to Pune, Nitin, if you're there, you can take it up.
Yes, sir.
Okay.
Am I audible?
Yeah, go ahead.
Good evening, all. I am presenting a case of 6-year female who is normal in birth and normal development and negative family history. And this child presented in September 2021 with she had one history of sudden loss of tone and fall. She was unable to walk for 15 minutes. She was aware, and there was left neck and left eye pain that was lasting for around few minutes, and then she was recovered. Later, after 7 days, she was brought to us with a similar episode associated with, now she had drooling of saliva, and she had intention tremor, hypotonia, and she had ataxia, and on examination she had left-sided hemiparesis, upper limb as well as lower limb, and she was admitted, and she was recovered within 3 days after admission, and that was the episode. After that, later on, she was symptom-free for the last 3 years. Currently, she's 6 years, and she presented in 3 years of age in September 2021.
Sudden loss of tone and fall, no aggravating factors.
There was no aggravating factor, sir, and she was aware, and she was at home, and mother noticed that. In the initial episode, she did not. They did not go to any doctor, and she was not intervened. After 7 days, she had again similar episode, and now she had this time she had developed left-sided hemiparesis. Lower limb also is 2/5 along with upper limb. Both side, upper limb and lower limb, left side, there was hemiparesis.
Okay, so unprovoked loss of consciousness and tone.
Yes.
That's to start off with. Okay.
Yeah.
All right. So I think we'll come. Do you want to? Was it done before the scan or after the scan?
Initial scan we can discuss later. That can be discussed.
Okay. So initial, I just have the film's baseline scan in September 2021, and you can appreciate the main changes are in the posterior fossa in terms of infarcts out there, more on the right side of the cerebellum, also extending up to the brainstem structures, predominantly the pons, also, and the left side of the cerebellum. So predominant bilateral cerebellar involvement, brainstem involvement in terms of predominant pontine involvement on the diffusion various sequences. On the flares, again, you can appreciate similar abnormalities which were predominantly in the posterior fossa. Angio and venogram was done. The veno is normal, the left-sided posterior fossa sinuses and the interjugular vein are hypoplastic, so normal variant. On the angio, I mean, we don't have the source images, but you can appreciate on the MIP images, the vertebral basilar arteries are hypoplastic, especially the right vertebral artery and the basilar artery are almost completely not visualized. The very thin strand of flow along the right vertebral artery, the left vertebral artery is also hypoplastic or reduced in caliber. This is the SAD sequence. There was no, in terms of herniations, no abnormalities at the time of scan. There is possibly some paucity of the CSF space around the ventral aspect of the thoracic space out there in the cervical region. CT had demonstrated an abnormality at the craniovertebral junction, so we'll probably look at the CT on the following slides. Yeah, so I think this was the investigations done after the first
Yes,
scans?
they were in the follow-up. Yeah. Yes.
Okay, so this was the go ahead.
Yes, sir. And later she was worked up. Hemogram was normal, and coagulation profile is normal, and ESR and CRP were negative. Ferritin D-dimer, and it was COVID era, and she was done COVID IgG as well. That was negative, and lipid profile was negative, and vitamin B12, homocysteine, and thrombophilia workup was also negative, including antibodies. ANA was negative, and lupus anticoagulant was negative. 2D echo was normal, and EG was also done. That was normal in the workup. And she was from the first presentation itself, she was started on aspirin at 5 mg per kg per day, and she was started on oral steroids at 2 mkd, and she was continued for the same for 6 weeks, then tapered, and it was continued. And in the meanwhile, in the follow-up, she did not have any of the deficits except mild hypotonia that also improved over the time, and she was well in between in the throughout till now, sir. Even in the follow-up, no deficits as of now.
Okay. Then we have a follow-up scan. We have a CT and MR. CT was I think only a plain CT scan of the neck and the brain. What you can appreciate is there's hypoplasia of the dens and there's an os orientarium out there. At least on these images, that is what I could pick up. And also at the level of the foramen, at the C2 level, the vertebral arteries exit. This was around 1.7 millimeters, and this was on 2.6. The measurements don't show, but I thought at least on the right side is more significantly narrow in comparison to the contralateral side. And I can be, I'm not exactly sure, but the vertebral arteries are usually around 3 to 5 millimeters in diameter. So both of these foramen are less than what we normally expect for a child at this age. Follow-up MRI, I think, was done in June. No acute abnormalities. We have chronic ischemic abnormalities predominantly in the posterior fossa. Associated with volume loss and stuff. But yeah, no acute changes. And then there was a repeat angio done. Again, there is you can see the vertebral vesicular artery system is not completely visualized. Again, there is some hypoplasia out there, slightly tilted images out here. Can you appreciate the vertebral arteries, especially the left vertebral artery, but the right is almost completely hypoplastic. They also had done a provocative angiography with the child and right and left lateral neckward turning movements, and I think this is the initial one. We can appreciate the vertebral artery is hypoplastic, so that is slightly a limiting factor, because if it was completely opacified and there was some stretching, that would have been better visualized. But I can see at least on these scans, the right vertebral artery is more hypoplastic than the left, and on the other side projection, again you can appreciate over there the vertebral artery turning up from the foramen into the intradural and the posterior fossa segments. So provocation angiography was done to look for possible Bow-Hunter syndrome. I think these are the questions. Nitin, you want to just elaborate? What are the main queries?
Yes, sir. Were there is persistence of the occlusion and the basilar artery as well, and vertebral artery occlusion? Is it the feature of vasculitis, and aspirin still the child is on aspirin like for last 3 years, and how long should that be continued? And is it the fetal origin of the PCS that is the only thing, or is it the thrombosis as well, plus that dynamic compression, sir? Bow-Hunter syndrome.
Yeah, just to put up we had few cases of Bow-Hunters. I think this is where the MRI was normal, but rotational angiography demonstrated, especially DSA, demonstrated paucity of flow of the distal circulation on the vertebral arteries. So at least with the the volume rendered images demonstrated some narrowing at the level of the foramen, again due to the ligamentous hypertrophy out there. This is again rotational angiography. The main concept is because of the stretching of the vertebral artery, there is repeated injury out there, and this causes possible stasis of flow and infarcts in the posterior fossa predominantly. We think that this was published last year, a couple of years back. This is what we thought for children with cryptogenic posterior circulation stroke to be followed. I will not go into detail. Vasculitis, I'm not sure. We did not do a vessel wall imaging, but at least on the T2 sequences, the phase sequences, there was no inflammatory changes or thickening of the walls. I don't have those images, but at least the plain sequences, I could not appreciate any thickening of the walls. So we're either dealing with a dissection, I think either dissection or a compromised due to the dynamic provocational abnormalities out there. This is again a paper published with review of 124 cases. This is what they followed for assessment. The main what they found was DSA was the main gold standard, followed by contrast CT. I think I'm not sure if the canal was commented, the stenosis or the narrowing of the canals of the foramen out there. So if that could be a reason for this child that the additional craniovertebral junction abnormalities causing these changes.
Nihaal, I had a question.
Yeah.
If we have a child who has a posterior circulation stroke, MRI done, stroke is there. So for not missing out these problems, next test, short of DSA, should we do a CT neck, CT angio, and a Doppler? Will that be good enough to pick it up with the rotations, neck rotation?
Yeah.
And do you have
I think
to
that
do
should
it,
be good enough.
Sideways rotation or the up and down as well?
It
So
usually, we do MRs. Usually we do an MR because it picks up the stroke as well, any small ischemia. But once we find that, CT would be ideal to look at obviously the bony abnormalities and a sideways. Usually the abnormality is on the sideways rotation where the vertebral artery stretches. So we do all four positions: flexion, extension, and the sideways rotations. But the main abnormalities are in the sideways rotations. If the child is unable to do all four.
So when you tell the radiologist to do it, so you tell provocational CT neck with CT angio.
Yeah.
Is that what you request?
Yeah.
What do you advise? CT angio or do you advise Doppler?
Doppler is just to look at the neck vessels, but to look at the cause of the compression, if there is any compression out there.
For example, when you're doing the Doppler, if you turn the neck and all, won't you see? You
will not find. If you want to look at what is causing it, is it a bony abnormality or a ligament which is causing
that
the
I
abnormality?
understand. Yeah. But for example, if you already got a posterior fossa stroke, and there is you basically doing a CT angio. There's a little more radiation and all that. That's why I asked. Is it like because it's a routine investigation in all posterior fossa strokes? That's what you're saying, right?
Yeah, the cryptogenic ones. If there is no infection, no trauma.
Most of the cryptogenic ones.
Yeah. So we do an MRI first, and then we look for CT.
You do a CT angio then, okay?
Yeah. No, we do the MR angio.
Yeah.
Then we do if there is demonstrable stretching, then it's fine. But we still go ahead with the CT spine to look for any if the neurosurgeon wants to operate on the child. So we usually get a CT neck and CT spine and a brain done.
So one doesn't need a MR angio. One can just directly do a CT angio.
One can directly do it. Yeah, if it's a first scan, and if you want to see infarcts and not miss in the CT, sometimes those hyperdensities are not clearly visualized on the CT scan, especially if they are small. If they're large infarcts, then CT picks it up.
Can I?
Please go.
So the dynamic CT angiography is not very possible because 3 times injecting and 3
that
times
was one more thing.
Neck is not
too much of
feasible.
radiation.
Yeah, it's a lot of radiation. So Doppler is difficult to interpret, but if you can do it properly, even the distal hyper resistance can be picked up by neck vessel vertebral Doppler. So having said that, I have no experience on that, but it is really possible. But the lowest radiation is with the DSA because you can do dynamics.
And it's the most sensitive. I think
the only problem is that that means what you're saying is that all posterior fossa strokes where you don't find a cause, you should do an angio, DSA.
I think if you have to do a SWA also in the neck, lower down, upper part of the neck, including the vertebral, because SWA will pick up very subtle dissections, which is very difficult to be picked up by TOF angiography. We have picked up any number of posterior circulation dissections by SWA. You look at the magnitude image of the SWA, which is actually slightly pushed up down to the upper part of the neck. So the terminal part of the V3, V4 junction of the vertebral, where the maximum dissections are there, can be easily picked up by SWA. If you are not seeing anything, I think you should still do a Doppler first with the dynamic, rotation of the neck. And if you have a still doubt, I think you have to directly go for a DSA, because that is the most sensitive, specific, as well as radiation effective investigation.
Yeah, thank you.
I had a child who came back at 6 years, first episode of posterior circulation stroke. 10 years later, while she was in 10th standard, she had another stroke before episodes of rotational vertigo. And she had this rotational vertebral arteriopathy, and we had to fixate the C1, C2. So there can be that duration of lag as well. So I think we should investigate all the cryptogenic posterior circulation stroke, which, as Roger said, most of them are. We should investigate and make sure we are not missing out on whatever the protocol we use.
So next question is, I think Nitin was asking, do we continue aspirin, and how long do we continue aspirin for this child? For this child.
So if you have addressed the primary issue with fixation, if it is a vertebral arteriopathy, then 1 year from the stroke, and then we can stop.
Does the child need to be in collar, Dr. Lokesh, or do you prescribe?
Only immediate post-op. Post-op we do that. And immediately after the stroke, if you are doubtful, then you probably high risk of suspicion, then probably keep them on collar until, because mostly you do the rotational vertebropathy usually after 4 to 6 weeks after the acute stroke.
Yeah.
So until then we can do.
So the foramen narrowing, does it come first, or is it because of the narrow vertebral arteries the foramen are small?
Yeah, that's an embryological question, but what I have seen is that in carotid canal narrowing, mostly the carotid canals are narrow, but vertebral artery, hypoplastic vertebral arteries, the vertebral foramen may not be very narrow like what you see in carotid, tangential carotid narrowing. So it will be very difficult to interpret that the vertebral artery is normal by looking at a normal CT vertebral artery foramen.
Okay, sir.
I think here a contrast, here a DSA or contrast would have been helpful. I think it's contrast angio to look at the vertebral artery along the foramen, if I'm not mistaken.
Can we confidently tell them that we can fix it by, doing a procedure there? Or
I think, Dr. Vijay, would you go to DSA now? Still, I mean, before surgical intervention is done, or?
Yeah, I think before any intervention, a DSA is 100% much, because you have to demonstrate that without any, because you are going to fix the child's neck.
Yeah. Okay, sir.
So I think neutral and provocative DSA followed by whatever is the result of DSA should be helpful.
Okay, sir. That's very helpful. Thank you.
Thank you, sir.
Calling the neurosurgeon at this point would be very helpful to get the people.
Yeah, we'll do that. Thank you.
Okay. Apura, if you're there, sorry, this case is from Vijayawada, not Hyderabad.
Hello?
Yeah, Apura, go ahead.
Yes, sir. So, a 9-year-old boy born of a consanguineous marriage presented with global developmental delay, motor more than speech and cognitive, and had mild intellectual disability. Along with that, the child had the dysmorphism. There were broad facial features and short stature. The child had fever-triggered seizures, and then gradually there was a progressive onset ataxia along with central hypotonia. So for this child, MRI scan was done.
All right. So MRI on top, we have the entire panel is T2 axials out here on top. You can appreciate some degree of supratentorial volume loss. There is some hyperintensity along the deep white matter, the centrum semiovale out there. You can see out here in the middle, the second image. Coming down to the deep brain nuclei, I thought the globus pallidus, the thalami are slightly hypointense. The thalamus overall is slightly reduced in size. There are again peritrigonal hyperintensities and some hyperintensities along the internal capsule out there. Coming down inferiorly, again, you see that the cerebellum has reduced volume. And on the SAG images, you can appreciate the volume loss of the corpus callosum and the brainstem structures, and also the kernel sequences. You have cerebellar more than cerebral volume loss. So yeah, some degree of atrophy out there, more in the infratemporal region. Some white matter abnormalities. These are possibly terminal zones of myelination, but again, these are slightly more abnormal in the peritrigonal regions, and the deep brain nuclear structures, especially the thalami and the globus pallidi, we thought were abnormal out here for this scan. Diffusion and SWS sequences did not pick up any abnormalities for a 9-year-old child. At this point of time on the imaging, we thought of possibilities of lysosomal disorder, especially NCL. If you see the resemblance of the imaging findings for this child and the child we had. So I think the genetics was sent with possibility of genetic abnormality and lysosomal disorders as one of the prime differentials. Yeah, Apurva.
Yes, sir. But when the genetics was sent, there was PUM1 gene mutation, which was spinocerebellar ataxia type 47, and it was heterozygous, and both of were absent in the mother and father parental segregation.
So it is a causative gene, is that right?
Yes, likely.
Okay. Then we looked up at PVM1 mutations, the SCA47 variant. It is known to cause spinocerebellar degeneration, one of the genes causing that. And this is from the phenotype for the CNS. On imaging, I could only find main abnormalities were pure cerebellar atrophy, that is type 47, again mentioned out here. So we wanted to check if there are any further experiences with the additional abnormalities seen in the brain and if it fits this genetic mutation.
Just out of interest, how many cases have been described?
Oh, very less, Dr. Urani. I think less, 5 or 6 is what I could find in literature.
You know, I mean,
Yeah.
nowadays
Or references, 5 or 6
pediatric
references.
neurology diseases have gone from 100 to 1 million. You don't know how many are there. Very difficult to really exponential.
Can I come back to the first slide? Didn't you mention dysmorphism?
Yeah.
Can you specify, perhaps? And can I remind you, I didn't know offhand, but I looked at OMIM, and there is a second entry in OMIM for PUM1 number 620719, called neurodevelopmental disorder with motor abnormalities, seizure, facial dysmorphism, and so on. So it appears that not only SCA47, but also another phenotype is possible. You may check.
So the dysmorphism is what means they mentioned short stature. Dysmorphism was I don't know.
So there was broad facial features were there, and some low set ears and stubby nose, but not like non-specific features.
So again, even if they mention it on the genetic report of this this variant, we still have to check for the other one, which is the one which I mentioned.
I just have a brief look. I haven't studied the literature, but you check perhaps OMIM entry 60719, and this is seems to be a different phenotype.
Yeah.
Sorry, what is the number over here? PUM1, okay. PUM1.
Yeah, so it's neurodevelopmental disorder with motor abnormality, seizure, facial dysmorphism. The dysmorphic faces are bitemporal narrowing, sloping forehead, pointed chin, low set ears, multiple abnormalities in the eyes, nose. Neurologically, they are mentioned again, vermin atrophy, thin corpus callosum. And again, six references for the gene. So
This actually fits better, isn't it? The patient had seizures too, right?
Yes, sir. Fever triggered seizures.
so the gene is possible, but the the phenotype can be different. Is that yeah.
Basically,
Well, this is not uncommon. We know many examples of gene variants with very diverse or very some diversity in clinical phenotypes. I'm not doubting the genetic variant of PUM1.
Yeah, just the phenotype can be different. Yeah. Okay. Okay, we'll have a look at that again and check with the genetics. Apurva, just follow up and check with it.
Yeah.
If it's the other one more than this one.
Yes.
Okay. All right. Thank you. All right, to our next case, Anas, you there?
Hello.
Yeah, Anas, go ahead.
Yes. So this is for a 3-month-old boy, born term child, born to non-consanguineous marriage, no perinatal history, admitted in view of recurrent fever and dull activity. He required prolonged antibiotics. So first admission in the neonatal period was at 18 days of life. He had prolonged fever and seizures. He was diagnosed as meningitis based on CSF analysis elsewhere. Following this, baby had 2 further admissions requiring IV antibiotics. The second admission was for a swelling over the occipital region, which was diagnosed as hematoma, and before which they used IV antibiotics and got resolved. Then so now we are seeing the family for the first time. They wanted to know the answer why the child is getting sick repeatedly and wanted to find some answers. So when we saw him, he had fever for 3 days. And we examined him. He was 4.5 kgs, head circumference 40 centimeters. There was some failure to thrive. Tone power was normal. But on examination of back, there was a sinus over occipital region and a sacral dimple near the anal verge, which prompted us to do the USG spine as well as MRI brain with contrast.
So I don't have the ultrasound images. We'll directly go on to the MRI. Also, on diffusion on top, you can appreciate multiple areas of restricted diffusion with some vasogenic edema surrounding it centered in the cerebellum, more on the left cerebellar hemisphere, also extending up to the vermis. On the T2-weighted sequences, again, you have these multifocal lesions predominantly demonstrating T2 hyperintensity with some hypointensities within it, and significant edema causing ascending transcensoral herniation out there. On the SWS sequences, you can appreciate punctate foci of blooming within some of these lesions. Post-contrast, there was some degree of meningeal enhancement out there in the anterior vermis, some ring-enhancing lesions out there, some incompletely enhancing lesions in the form of late cerebritis kind of features is what we thought. And again, you can appreciate the extension of the lesions. The main lesion out here is in the left cerebellum, extending, crossing the midline structures out there. Spectroscopy was done, and what we could appreciate was a significantly elevated lipid peak out there. The NAS was reduced, creatinine was reduced, the cholines for an infant, I think, is mildly elevated, but not very significant, is what we thought. Spine study was done. This is a non-contrast T1 variant sequence. We did not do a CT scan, but what we thought there was some abnormality in the cervical vertebrae out there. We see the height of the vertebrae is reduced. They're more the morphology also is abnormal in comparison to the rest of the vertebrae. There was a terminal lipoma out here, and the cord was tethered. Coming down to the cervical region where the sinus was presumed to be present, you can appreciate some abnormality out there along the dorsal aspect of the cervical cord. But appreciate on the SAT sequence, and you can see that there is a tract emerging from the upper cervical cord going up to the suboccipital region. I'm not sure if you can appreciate that on the axial sequences, but this was the tract going down, and there was spina bifida out there. And this is the axial section of the low lumbosacral region. Again, you can appreciate the lipoma. Post contrast, we could not appreciate any enhancement of the sinus tract, but again, the lesions out there in the cerebellum and possible segmentation anomalies in the cervical vertebrae and the lumbosacral vertebrae. We thought of a consideration given that the child had recurrent infections, tuberculosis as one of the possibilities, given the spectroscopy appearance, possible tubercular abscess. Was considered with, I think, the differential of fungal and pyogenic infection down the line. Again, different ring enhancing lesions. I think we have discussed this previously. And the follow-up, Anas.
So the initial investigation just showed elevation in inflammatory marker CRP, ESR. He had done uric acid as part of screening. First scale, it was normal. So after the neuro imaging, a suboccipital crinotomy and excision of the dorsal occipital region dermal sinus tract was removed, and there was evacuation of the cerebellar abscess. We had sent it for culture, and which showed MRSA. After which we had, he was just, and his antibiotics were optimized. He's been discharged now. He's been doing fine. No further fever spikes as such. So another thing, what we're because he had some on X-ray there was fused rib and some possibility of vertebral segmentation disorder, and this along with addition of the spinal deformity. We were wondering if it could be a part of a genetic syndrome. So we asked our geneticist, and who advised whole exome. So parents wanted to think over it, and on follow-up we plan on sending it. But otherwise, the child is doing fine.
Anything specific from the geneticist, Anas?
They were thinking of Klippel-Feil syndrome as one possibility, but the springal deformity is not there.
Not there.
So
Yeah.
not all features are matching, but one of that was one of the thought process.
Okay.
Initially, initially there was any immune disorder were considered, but once we saw the sinus tract, possibility of just the tract being the source was considered, and that line of workup was not done. Immunology workup was not done. Okay.
Was there a positive bacterial culture during the first episode of meningitis?
So he was his workup was done elsewhere. So at that time they could not find a culture. At least they had done a culture, but did not grow anything. But it was done at a different center. We don't know how they have grown this thing, but at least we had a documented report of negative culture. He was treated empirically with broad spectrum antibiotics, vancomycin and meropenem for 21 days.
As an old person, for me, a learning point, not a criticism. If you have a young infant with an unknown meningitis, you need to carefully look and search for sinuses and tracts along the skull and the spine.
Yeah, most definitely, sir. Yeah, that was
it's very cheap.
Yeah, I absolutely agree. As being another old person, that we need to have a magnifying glass to actually look at the spine properly. Yes.
Yeah, absolutely. Not being older, younger, or middle age or anything, I think it has to be done.
And based on the same theme, there was a review of literature, and you can see that there are recurrent cerebral abscesses due to dermal sinuses and dermatitis in children, and Staph aureus was the most common organism.
Yeah.
This is from 2019, if I'm not mistaken. As you can see, evaluation of the entire spine if there's a posterior fossa abnormality. I think it's helpful.
Nihaal, can you show that spectrum once more?
I have not seen these peaks in pyogenic tubular, if you can.
Now this patient's spectroscopy.
Yeah, these patients.
See this. There is a strong lipid. In addition,
Yeah,
I think there is some succinate also there,
yeah,
because between Na and choline.
yeah, around
So that
2.4.
is
Yeah,
not usually seen in tuberculosis.
okay.
So
So that
is this for my information? This will be seen in most abscess, any abscess, or?
Yeah, succinate and acetate will be seen in most abscesses, mostly in anaerobic abscess or facultative mixture of facultative aerobes and anaerobes.
I see.
And the cytosolic amino acids, I think 0.1 there is a downward peak. Cytosolic amino acid is seen, I think.
Can you please point it out?
The downward peak to it on.
Yeah, downward peak, that
Okay.
part. So if it is there, usually in Staphylococcus abscess, the cytosolic amino acids will be used up by the Staphylococcus. Whereas non-staphylococcal abscesses, this cytosolic amino acids are seen. But I'm not sure in this particular case whether it is just lactate or amino acid, because it is not exactly at 0.9. The cytosolic amino acids are at 0.9.
Yeah. To slightly before, 1 and
Yeah, that is
just before
sometimes
1.
it is 1.5 Tesla. This is not very accurate. The spectral spread is not very accurate. May not be exact.
Okay.
But this acetate is definitely saying that it is unlikely to be tuberculosis.
Okay.
I mean, the succinate is.
Yeah.
Succinate, sorry. Yeah.
Thank you. That was most informative.
So do we need to send for genetics is the second question now.
Not really. Yeah.
Not really in this situation.
Yeah. Okay. Then no other comments. Yeah, we'll move on to our next case. Anna, over to you.
So he's a 7.5-year-old boy. He had polymorphic epilepsy, head drop, spasms, and multifocal seizures with intellectual delay and behavioral issues. So he's on follow-up. He presented. He had some occasional headaches on and off, but this was not the presenting complaint which he had come with. He attained seizure control since past 1 month, and had come for OPS for a scheduled follow-up.
This child was diagnosed as tuberculosis, no? Tuberous sclerosis, sorry.
Yes, sir. Tuberous sclerosis, but genetic evaluation.
Wait.
Right?
Okay.
Yeah.
Sorry, go ahead.
Just in terms of terminology, not criticizing, the term is angiofibroma and the term sebaceous adenoma is dismissed. It has nothing to do with the sebaceous glands. It's called angiofibroma of the face.
Okay, thank you.
Okay, so you want to word the scans?
Yes.
Okay. I think there are multiple scans, but this is the most recent scan, and you can appreciate there are multifocal abnormalities. I can appreciate some cortical tumors out there. Lateral ventricularly with a lesion out there in the subependymal region, centered in the frontal horn on the left side. The measurements were around 25 millimeters across with 50 millimeters to the transverse dimensions. Contrast spectroscopy wasn't done. Only a plain study was done. Some subependymal nodules also were demonstrated, some of them demonstrating the mineralization on SWI sequences. Midline salad sequence again demonstrates the thin out corpus callosum, slightly reduced volume of the brainstem, and the lesion out there center in the lateral ventricle. I don't have any other sequences. There are no other abnormalities on the other sequences. No diffusion abnormalities or no restricted diffusion, and contrast was not done. Yes, so yeah, these are the main findings for this child. Transmental lines, cortical tubers is what we thought of. Subependymal genital astrocytoma out there, and some subependymal nodules which are calcified.
Yeah. So as part of surveillance 2D echo of the USG abdomen, he was on follow-up. So these are all very negative. EEG over the years from 2017 showed at various point of time multifocal discharges, hypsarrhythmia, generalized spike and wave discharges. His LFT lipid profile as part of workup was normal. His whole exome sequencing showed DEBDC5 mutation. It was present in the father and absent in mother. But I think phenotypically he was in the mTOR pathway.
Has the father any symptoms? I may have missed this point. Is the father healthy?
Yeah, he's asymptomatic. No seizures for him.
Thank you.
Question here, Anas, specifically the absence of TS, the main genes.
Yeah, just as part of
okay, part of the mTOR pathway related disorders.
Yeah,
But
but I think in TS, I think about 10 to 15% have no mutation identified, and it might be a somatic mutation probably rather than, so the blood maybe in NMI, I think they call it about 10 to 15%.
So, sir, in that cases, would tumor, I mean, sending genetics from tumor help us if we excise the lesion?
Yeah.
I suppose it could, but I don't see, I mean,
no point.
I mean, I'm not sure. I mean, there's no doubt about the diagnosis. It's just
Yes.
the question of the mutation is not seen. So,
Can you
PC5
repeat
is a problem
what-
because it's seen in familial. Sorry, I'm sorry.
What is the diagnosis? I'm confused in one point. I don't know the literature completely, but DC5 cases have been associated mainly with hemimegalencephaly and focal cortical dysplasia.
Right, absolutely.
Angiofibroma of the face.
No, I think
been mentioned.
I think the diagnosis of tuberous sclerosis is clear-cut both clinically and radiologically. I think it's only that in a certain percentage, and if I remember right, it's about 10 to 15%. I had reviewed this a while ago. There's no mutation identified either, in WES or in the CNVs or anything of that sort. So basically, that those 15% are assumed that I'm assuming that there may be a mutation in the somatic mutation rather than anything else.
Okay.
So if you're a good candidate, you send it for, if you operate on the Sega, maybe you can send it for, it would be interesting.
Yeah, we have operated the child today. We have the tissue.
Okay, so we just wanted to show the case with it, without the typical mutation. Yeah.
Rajesh, one quick question. So, how frequently have you seen this? We have seen 3 over last 10, 12 years. Segas.
So, well, you see it. I think it over time it becomes more. I mean, since the Sega might become bigger over as the child ages and becomes an adolescent. So you might see more. As a percentage-wise, I'm not sure how many really have it, frankly.
Okay. Sure. Thank you.
Was it completely excised?
Yeah, completely excised.
Because even if you leave a small amount behind, and if there's a bilateral Sega, then the chances of recurrence are very high. So,
if we keep on everolimus, does that help in this situation to reduce the growth?
If it is a problem, if it is not causing any issue, then you can just watch.
Okay. Sure. Thank you.
To our last case, I think this is a follow-up case. If Rashmi, if you want to just quickly brief us about the clinical presentation.
Yeah, so this was a case we had discussed earlier. So this was a child who was diagnosed as cerebral palsy, and they had come on with focal onset status epilepticus, but now she's very well controlled. So after that admission, which we had that time, the second episode, she's very well controlled on valproate and levetiracetam. But we're still getting to the bottom of why she's got these episodes, why she's got global developmental delay and increased tone and all that. So last time we thought that the MRI didn't fit in with perinatal etiology because there was no history of perinatal etiology also. So we thought it could be tubulinopathy. So this time we've got a genetics back, and I just wanted Dr. Nihaal to correlate because there is a TUB4 variant which has come in this girl. So.
Okay, so this is the MR sequences which we had. I think this was the only initial scan we had. On top of the flare sequences, some dysplastic ventricles out there and asymmetrical dilatation. The basal ganglia are dysmorphic, and there is some degree of volume loss in the supratemporal brain, predominantly in the frontal lobes. Also, I think brainstem structure also reduced. We should be better appreciated on the SAT sequences if we have them. But yeah, on the SWA sequences, we did not appreciate anything. Nothing on the diffusion abnormalities. On the SAG, you can appreciate. I think we didn't have a T2, but you can appreciate that the brainstem and the cerebellum is hypoplastic out there. Yeah, so based on that, we raised the possibility of
is the ALIC absent? I mean, I can't see the anterior limb.
Yeah, it is. Yeah, that's dysmorphic. Yeah, we don't have a T2 axial, but on the flares you can see that there is no ALIC. So yeah, dysmorphic ALIC, basal ganglia with the absent ALIC sign.
Yeah.
That pointed us to a possibility of tubulinopathy as the prime consideration on imaging and not a perinatal injury. And this was the gene which came out with a variant of uncertain significance. Is this the only one?
No, there was one more, no, in that.
Oh, okay.
TUB4 also was there.
Oh, okay. Sorry, I think I missed the second page. If it's a TUB4, then it correlates. I mean, I thought it was only a. If you can you share it on the chat if possible, or?
I'll share the. Actually, I can share the variant on the chat. So the
yeah.
MAS3 came in the main thing.
Okay,
but then what they have put is in the second page, they have raised two variants. One is RELN.
Yeah.
Because I think they probably didn't know. So RELN heterozygous and autosomal dominant, and TUB2A, not TUB4, sorry, TUB2A.
Yeah.
I'll share it right in the chat.
Yeah, I got.
You got it?
So the imaging correlates.
TUB2A was a missense mutation. So
okay.
Global developmental delay, seizures, thin corpus callosum. That is what they have written.
Yeah. RELN, I don't think matches. We have Agan here and Tuvija if they want to comment. They usually are alobular appearance of the vermis, some hypoplasia out there. And supratemporal findings, as there is some cortical malformation in terms of lissencephaly, pachygyria, typically seen in RELN, and the basal ganglia is not a common feature, which is seen in tubulinopathies and not in the renal pathway mutations, as far as I know.
So we could go on TUB2A, is it?
Yeah, I think TUB2A is a close match, yeah. If anyone else wants to comment upon that, yeah.
I agree. I think this is more like a tubulinopathy than Reddy. Reddy can produce tactile hypertrophy, completely Fermian hypoplasia, and other abnormalities.
Yeah, but the supratentorial doesn't match. So
supratentorial is more like a. Only thing that polymicrogyria complex is not seen in the frontal lobes. Do you agree, Nihaal? That troublesome lissencephaly polymicrogyria that can also come in tubulinopathy. May not be necessary, but it is not seen. But the brainstem is very classical, I think.
So we can go with TUB2A, because it's a missense mutation, and missense mutations are usually pathogenic. Because it's not been reported before, they have reported as variant of uncertain significance.
Parental segregation?
Parent, I haven't done. I just got the report last week.
Yeah. I think we'll have to go there.
The next step will be to do for the parents and then see.
The basal ganglia fusion also, I think it is favoring.
Yeah.
Basal ganglia also goes in favor of tubulinopathy.
Yeah, tubulinopathy.
Okay.
So yeah, I think it's it's a match.
Okay, thank you very much, Dr. Nihaal.
I've shared the reference on the chat. You can just check that. So yeah, that should be our last case. So thank you, everyone. We'll meet again in 2 weeks' time. Dr. Vijay, you want to say something regarding the weekend?
Yeah, I think I don't know whether you got the information. We have the Indian Society of Pediatric Neuroradiology midterm CME, both the cardiac and neuro sessions tomorrow and day after tomorrow, happening at Sri Chitra Tirunal Institute. If anybody wishes to come, you're most welcome. So Nihaal will be joining us, and also Gopi and other stalwarts.